All right. Hey ho, let's go. This is Resistance Radio, where natural selection selects resistance, and we try to keep our surveillance systems just one step ahead. Today, we're closing the book on the 2026 Andes hantavirus outbreak linked to the Dutch flagged expedition cruise ship, the MV Hondius. Think of this as the director's commentary track of what happened, what we learned, and why this didn't become the next pandemic, despite checking a lot of boxes that make us epidemiologists sit up straight. So let's start with the basics. Hantaviruses, as we know, are a group of rodent borne RNA viruses that humans mostly encounter the hard way by inhaling particles from rodent urine, droppings, and saliva. They're scattered across the globe, but clinical syndromes differ geographically. Hemorrhagic fever with renal syndrome occur in parts of Europe and Asia. Hantavirus pulmonary syndrome or cardiopulmonary syndrome happens in the Americas, which is what we saw here. The Andes virus, the star of our unfortunate cruise ship story, is endemic in South America and is one of the strains that causes severe lung diseases, which fluid is filling the lungs, rapid regression, and all this can be associated with high fatality rates. Most hantavirus follow a comforting rule. They do not spread amongst humans. However, the Andes virus is the exception. It can transmit from person to person, but only under very specific conditions, close, prolonged contact, often in closed environments, and historically in small clusters rather than large chains. So when you hear the quote unquote novel outbreak and human to human hantavirus, that's not clickbait. That's actually a legitimate concern. So, okay, with all that in the context, let's talk about the outbreak. On May 2nd, 2026, the WHO was notified under the international health regulations of a cluster of severe acute respiratory illnesses on board the ship, the MV Hondius, which was sailing in the South Atlantic. At this point, we had had two deaths and one critically ill passenger with a severe pneumonia picture and negative testing for all the usual suspects. This kind of infectious disease makes teams start running through their zebra list, right? Atypical pneumonias, sepsis, vector-borne diseases, and emerging pathogens. Now, the turning point came when hantavirus cardiopulmonary syndrome was added to that differential, and samples were sent to the National Institute for Communicable Diseases in South Africa. Hantavirus PCR lit up, and sequencing confirmed the strain, the Andes virus. That diagnostic pivot away from yet another viral pneumonia and toward a rodent borne pathogen, which changed the entire framing of the event, as we know. Now, by early May, the ship had already on board 147 people, 88 passengers, and 59 crew. As the situation evolved and more countries started testing evacuated patients, the case count settled at about 13, not at about, they settled at 13 linked to the ship. 12 laboratory confirmed Andes virus infections and one probable case with three deaths. And if you want to picture that numerically, imagine a mid-sized high school, let's say, with 500 students. 13 cases would be like the entire school having one infected classroom, and three deaths would be losing about half of the people in that room. These are small numbers in absolute terms, but brutally high severity for those that were affected. Now, the outbreak fatality ratio came to about 23%, three deaths out of 13 cases. And historically, hospitalized Andes cases often see case fatality rates of 30 to 50% range. So this cluster sits on the lower edge of that envelope, but still firmly in the this is a dangerous virus territory. All the known cases were among people who had been on the ship, and among those needing hospital care, most recovered. But still, two were hospitalized at the time the WHO issued this final update. Now, from an epidemiological perspective, the timeline is telling. The index case, we'll refer to that person as patient one, developed symptoms on April 3rd, just 2 days after departure from Ushuaia, and had spent about 3 months traveling through regions of Argentina, Chile, and Uruguay, where the Andes virus circulates in rodents. Now, that incubation timing days rather than weeks post embarkation strongly suggests an initial zoonotic exposure that happened on land before the cruise even began. Now, subsequent patients, including the partner who died in Johannesburg and the critically ill patient evacuated to South Africa, showed a tight clustering in time with symptom onset and progression compatible with both rodent exposure and limited human to human transmission aboard the ship. Early sequencing showed the virus sequences were almost identical, with at most a single nucleotide difference between patients. For the science geek in the audience, that kind of low diversity across spatially confined cluster screams point source introduction with short chains of secondary spread, not multiple independent spillovers, and is certainly not a rapidly new variant. So, what does that mean? It probably came from one source. So let's talk about the transmission. The WHO and the European CDC both assessed that human to human spread did occur on the ship, but remain limited and context dependent. The hypothesized routes included direct contact with infected individuals or possibly contaminated surfaces, direct deposition of respiratory particles onto facial mucosa, and possibly some degree of airborne transmission in poorly ventilated spaces. However, the attack rate amongst passengers and crew and the absence in secondary chains once people left the ship clearly did not match the profile of a highly transmissible airborne pathogen like measles or what we saw early in the COVID-19 pandemic. If you want a mental model, think of transmissibility on the dial of 1 to 10. Measles lives at a 10, whereas the SARS-CoV-2 virus lives at around 8 to 9. The Andes virus in this context is probably somewhere between a 2 and 3, capable of spreading under very specific conditions, but not especially eager to go looking for new hosts once those conditions disappear. So let's talk about symptoms now. The response was frankly impressive. The WHO and the European CDC, the national public health agencies, and local health authorities coordinated an international investigation and contact tracing efforts across 30 countries and territories. They tracked not only just passengers and crew, but contacts on 2 different international flights, healthcare workers, airport staff, and close contacts of cases who disembarked in remote locations like Tristan de Cunha and St. Helena. By the end, 317 high risk contacts completed 42 days of formal quarantine and monitoring, and over 330 low risk contacts completed self monitoring. Think of this as 2 full plane loads of people, every seat filled, asked to press the pause button on their lives for 6 weeks because a virus with a very long incubation tail might still be lurking. The incubation window for Andes is typically 2 to 4 weeks, but cases up to 42 days post exposure have been documented, and that shaped the quarantine guidance. So, what was the final result? Thankfully, there was no additional secondary cases detected amongst those hundreds of contacts. That's the quiet part of outbreak response that doesn't make the headlines, right? The absence of something happening because a lot of people did the right things consistently for a long time. Meanwhile, diagnostic labs in multiple countries validated and deployed PCR assays for the Andes virus. They shared protocols and coordinated reference materials through the WHO channels. Genomics teams compared sequences from cruise ship cases and with regional strains in Argentina and Chile to better understand origin and transmission patterns. A prospective natural history study was set up across 21 countries to track exposed individuals and learn more about viral kinetics, immune responses, and determinants of severe disease. In other words, not just containment, but knowledge building. So, where does this leave us in terms of risk? For the general public in Europe, the Americas, and beyond, the WHO and the European CDC have concluded that the risk of the specific event was very low. The reasons were straightforward. One, Andes virus does not spread easily between people. Transmission remains rare and tied to close and prolonged contact. The natural rodent reservoir for the Andes virus does not exist in Europe or the American or the US for that matter. So there's no local animal source to sustain community transmission there. And lastly, all 13 cases were linked directly to the cruise ship. No onward community outbreaks have been detected. And at the same time, the underlying reality hasn't changed. Andes virus remains endemic in parts of South America. It causes high severity cardiopulmonary syndrome and lacks a specific antiviral or licensed vaccine. Survival still hinges on early recognition and rapid supportive care, especially intensive respiratory and hemodynamic support and good infection prevention and control. So, what are the big take home lessons from Hanta 2026? First, severity is not destiny. A virus can be very lethal at the individual level without being globally disruptive if its transmissibility is low. Andy's virus reminds us that bad for the patient is not automatically bad for the planet, but also that we owe each patient and each cluster very serious attention. Second, context is king. A confirmed maritime environment with older passengers, shared spaces, and long exposures created the perfect conditions for a small chain of transmission. Once that context vanished, once people dispersed and the quarantine began, the virus struggled to find new hosts. Third, systems work matters. International contact tracing, 42-day monitoring, shared lab protocols, and clear risk communication took a scary, rare pathogen with human-to-human potential and kept it from becoming anything more than a carefully managed incident. The absence of a disaster is still an outcome, even if it's less cinematic. And finally, genomics and global cooperation are not nice to have add-ons. They are the core to outbreak tools. The ability to say with some confidence that this is the same old Andes virus and not a new super spreader variant reshapes public perception and policy. Okay, so the World Health Organization has now declared the MV Hondius Andes hantavirus outbreak contained and over. No further related transmission is expected. The cruise is done. The quarantines are finished. The data are quietly being folded into the next generation of guidance and protocols and research. So, where does this leave us? In a world where a virus carried by South American rodents can hitch a ride on human mobility, spending a few alarming weeks on a cruise ship, mobilize 33 countries' health systems, and still end as a footnote rather than a headline, that's not an argument for complacency. It's an argument for preparedness that is proportionate, that's science driven, and is humble about what we don't know yet. So there you go. My name is Mark Calendari. This is Resistance Radio, where we remember that not every spark becomes a wildfire, but you still build the fire breaks before the smoke shows up. Thank you for tuning in.